and discuss and be part of a conversation around childhood TB. My name is Lucica Dițiu. I am the Executive Director of the Stop TB Partnership, and I have a very great pleasure of co-chairing this event together with my colleague and friend, Dr. Jeffrey Campbell, the Assistant Professor of Pediatrics at the Boston University and Avedisian School of Medicine. Before going to the content of this, I just want to say three things about this event. First of all, we are in the year 2023, and as all of us here know from our practice and so on, TB is with us for hundreds of years and still doesn't give up in killing people and doesn't give up in really disappearing from our world. What is more dramatic is that in the year 2023, we have at least 700 children every day dying of tuberculosis. Dying of TB is a big drama. Having TB is a big drama in the year 2023, because we know very well that in the vast majority of cases, children with TB have the disease because of the adults. Actually, having children with TB is a very pretty good indicator of a non-performing program, because it means there is a lot of transmission going on. There are a lot of adults around the children that can infect them. It is time to really have robust conversations around this and understand that being in the year 2023, we should not accept anymore the status quo, and we should stand up and, as an entire community of researchers, clinicians, donors, but in supporting people affected by TB, children that had TB and their families, in making sure that they are going through the disease. In September 2022, WHO issued the new guidelines for addressing TB in children and adolescents, with a lot of new recommendations related to the diagnosis, related to the shortening the treatment, the use of bedaquiline and the lamanid, and so on. That is a very good step, and really thank to our colleagues from WHO for doing it. Later in 2022, we came together in the Stop TB Partnership, and together with our colleagues working on childhood TB or in pediatric diseases, we produced together. I actually didn't, because as some of you very well know, I am not a good in writing, and I'm a procrastinator in things. We had 5 articles published in the supplement of the Journal of the Pediatric Infectious Diseases Society, What's New in Childhood TB, covering different topics, from diagnostics to vaccine, from case detection to treatment, and as well the social determinants to ensure adherence, and so on. We couldn't have everything from that article. We couldn't have everyone to speak. There are some angles that will be presented today. And the beauty of the webinar today, the beauty and the light of it comes from the fact that it's the first time in which we have a childhood TB webinar in which an amazing kid that survived TB with her father are joining us. And I feel emotional, because this is what all our events should be about. They should be about keeping at the core and as close to the heart as possible all the people and the children affected by TB, to be able to bring all that energy and love that we all need to really fight for them, for their rights to access the right diagnosis, treatment, and prevention for TB. We should not accept in the year 2023 that people do not have access to the right type of diagnosis and treatment and care for tuberculosis, and we should not accept to have children dying and suffering because of TB. And we should demand this with our heads up, not only in the webinars and so on, but during the entire year and the UN high-level meeting that is going to take place in 22 September 2023. So I have a great honor to introduce the first of our speaker in giving us opening remarks. It's coming from a country that stepped in a lot in supporting childhood TB, and that is Japan. I am very thankful to the Ministry of Health, to the Ministry of Foreign Affairs of Japan for the efforts that were done to really support, together with our colleagues from the US government and others as well, in really deploying at country level diagnosis and treatments for children with TB. Mr. Tetsuya Itani is the director in the Office of Global Health Cooperation, Ministry of Health, Labor and Welfare of Japan. And sir, I would like to give you the floor for a few opening remarks. If you can go ahead, sir.
Okay, thank you very much. Dr. Ruchika Detail, Executive Director for Stop TB Partnership. Dr. Jeffrey Campbell, Assistant Professor of Pediatrics, Boston University, Chobanian and Abedisian School of Medicine. Distinguished delegates and everyone. It is my great pleasure to deliver a brief statement at the beginning of this important webinar. First of all, congratulations on the publication of important articles in the supplement of the Pediatric Infectious Disease Society, and also on this landmarking webinar. Taking this opportunity, I would like to highlight 2 points as a reference. One, Japan's history of how we address TB, and 2, Japan's contribution to the global childhood TB response. Let me start with introducing Japan's successful history.
They're just doing the introduction for this TB thing.
Can you guys mute yourself? Mr. Itani, please go ahead. Mute yourself because we can hear you. But Mr. Itani, go ahead, please. Thank you. You are muted, sir.
Okay, yes. Where? Okay, in Japan, since 1930s to 40s, TB infected many citizens, including children, and became the #1 cause of death. Then, Japan started its TB approach with the TB prevention law legislated in 1951. Based on this law, the government of Japan established a program for screening and treatment of TB all over the country, followed by the registration and management of TB patients. These interventions contributed to the remarkable reduction of TB patients by 10% annually, the fastest speed in the world at that time. This was an unprecedented accomplishment in the world. And finally, since 2021, Japan has been officially a low TB burden country. Learning from these lessons, Japan has continuously provided support to the international TB countermeasures, especially childhood TB. In 2019, Japan started partnership and the contribution to Stop TB Partnership for the distribution of child-friendly oral TB treatment regimens to replace injectable drugs. This distribution has been expanded in over 50 countries through funding scheme from the Global Fund and other sources. Japan also funds the development of new TB diagnostics and supports research and development of urine tests. This year, TB High-Level Summit and the UN High-Level Meeting on TB will be held. Including these high-level meetings, I hope that the global coordination to fight against and advocate for TB will mark an important milestone for ending TB by 2030. Japan is continuously committed to taking the leading role in global health, including childhood TB. We hope that the supplement of the Pediatric Infectious Disease Society will contribute to accelerate addressing childhood TB. Reaching and diagnosing all children with TB is a very important step to achieve universal health coverage. Thank you very much.
Thank you so much, Mr. Itani, for your intervention and also for your continuous support to really understand that, to really support that we go in this world towards ending this airborne infection, this airborne pandemic that is tuberculosis. So I'm very honored now to really invite our most important guest speaker of today, which is our child TB survivor, Sedia, and her father, Mr. Papasu. They are joining us from Lagos, Nigeria, more specifically from Badagry, Lagos. And Sedia is 13 years old. She's not only a survivor and a fighter and our newest champion, but she's an amazing human being that went through all the difficulties of the disease. We hope the connection goes well. We are very grateful for the support we had from our friends from Stop TB Nigeria and Funke, who did most of the work with the colleagues and the family here. So without further ado, we will try to do, we have, as you realize, we have a connection here from different parts of the world, and sometimes they work, sometimes they don't. I want to check if Mr. Papasu and Sedia, can you hear us?
Yes, we can hear you.
Excellent. So, sir, and my dear Sedia, we have, we will try to do it as simple as possible. So I don't want to put too many questions, but if you can tell us a bit of your story, around how did you how was the first time that you find out that you had TB? How long did the treatment take? Did you go to the hospital or did you go to the school? If you can share with us a few of these thoughts, please.
Hello.
We can hear you, Sedia.
Okay. Good day, everyone. My name is Musa Shedi. I want to say my experience on TB. It was a cool morning around 8 or 8:30 a.m. The principal of my school called us to the assembly ground. She told us that there are some visitors around us, and the visitors are nurses. They are from General Hospital. The purpose of them in our school is that they want to do tests for students. Our principal told us that we should inform our parents. When I informed my parents, they said I should do it, and I did the test. It was TB positive. I was shocked. When I told my mom, she was unhappy. The nurse called my mom from General Hospital and explained some things to her, and they told her that we should go to Yaba, the hospital at Lagos State. When we reached Yaba, we did tests and sample. At the end of everything, I was given drug to be taken. I used the drug for 9 months, from February 2022 to October 2022. During that time, I don't feel bad because the drug I'm using is free. I did not pay for it. Even the transport fare, I did not pay for it. They are the one paying. And my parents always support me. They always advise me and monitoring me how to use the drug. I always feel tired. And whenever I use the drug, I always feel tired. But I thank God that now I'm okay. And many people, any parents that their child has tuberculosis, that they should take good care of them. And they should show them love. Yeah. They should try to make them feel happy and special. And they should make them feel special. And they should not separate their plates, cup,
I think we are experiencing some connection issues, but we heard you, Sedia, and I just wanted to ask as a closing comment from you, if possible, if you still hear us. I see some comment in the chat. We can see on the main screen, I can see Sedia and Mr. Papasu. I can see them, and I hope they can see us as well. I wanted to see if Mr. Papasu, as a father,
Yes,
what do you can you advise to the other parents to do if they have kids with TB, but also more important, what would you like to see happening to support more the families with children with TB?
Thank you. Everything, we have to thank God for everything. Especially Africa, we in Nigeria, we don't believe in drugs. But to this, I really thank government, and I thank God for our life, for my daughter's life. Firstly, I will advise mothers in everything to show love. They are the one that gave birth to the child. So when the child has TB, they should show love. Bring her close, address her. This is how you use the drugs. Don't be afraid. You are not going to die. Monitor her. This thing is not thing that will kill you. You will not die. Continue, follow the doctor's prescription on how to use the drugs. No discriminating, show love and care. Monitor on how to use the given drugs regularly. So I will thank the Nigeria Stop TB doctors that show love and care. So to the parents outside there, TB has cure. When you follow the rules and regulations given to you by the doctors, surely you will cure. Look at Shide here today. You use the drug for 9 months. The doctor that tested that he has TB, that the one that also said that he has been cured. So you have to follow the rules and regulations. So to my Nigeria's family, they shouldn't be afraid. If their child have TB, they should do the necessary thing, consult the doctor, they'll give them drugs. Exactly like she did. They give up drugs, and they will follow the drugs, when to use it, when it's due to use it, and then go for it again. I'm not tired. Good 9 months. I'm not tired. I continue using it, and I know and I believe that it will stop. So she didn't die. Look at her. Since February 2022, this is Shady here. Since February 2022, using drugs, and it is not 1 dose. It is not 2 doses. The dose is almost like 10 piece of drugs, and she'll be using it. Whenever she uses it, she will weak, she will fade down. I will go there with her mom. We'll be looking at her. Is she sleeping? How do you feel now? She said that she's weak. Don't worry. It is the drugs that is working. Just feel free. And when she was using the drugs, she eats 4 times. The drugs make her eat. You'll be eating. She will be eating. Yeah. So when she uses the drug, she eats every day. So I believe that the drugs she's using is working. So I believe in the drugs. So no fear. I will not fear. So to my parents, show love to your kids that have TB by showing her love. Take her out, show her, go to a main event center, to tourism, to make her happy. So when it's time to use the drugs, draw her close. Okay, this is how to use the drugs. Okay, take this.
I think.
And you'll be okay. So
go ahead.
I will also plead our government here in Nigeria. Yeah. Are you with me? So our Nigerian government, the Nigerian Minister of Health, So Nigerian Minister of Health, right? So they should keep providing drugs. Parents will not be afraid, but many where can I get money to buy drugs? By providing drugs, their mind will be so okay and rest. So I say thank you to the organizer, Funke and Co. Their love shown to us doing the running up and down for Shidi to be okay. So I say thank you to Funke and his members. So I also say thank you to you, Madam Lucia, Madam DT. So I will say thank you to you and to everybody watching us from Nigeria. So I will say thank you to everybody and to everyone that their child or the person has a TB. We should put our mind at rest that there's cure for TB. There's total cure for TB. God bless you. There's total cure for TB. So there's total cure for TB. So there's no afraid. You will not die. You will not die. Look at her. Say hi. Say hi.
Hi.
Hi. Look at her. Very fine. Very fine. So there's remedy. If you can follow the rules and regulations given to you by the doctors, if you follow the rules, you'll be okay. So TB is not a death sentence. If you get TB, you are not going to die. You will not die. Follow rules and regulations given to you by the doctors. So to me, I'm very, very sure that having TB is not the end of your life. You are going to survive. As I survive, other people also will survive. As Shede survived TB, other child over there, they will also survive TB. And to everybody that has TB, they will survive. As Shede survived, we will also survive. Thank you.
Thank you.
Thank you
Thank
to
you.
you, Mr. Papasu, and thank you so much, Sedia.
Thank
And
you.
Thank you, ma'am.
I would just want to hear you, Sedia, you have such a cute voice and you are so nice and brave. And I hope we can have you with us in other events as well. For the children with TB, do you want to say just one sentence, Sedia? Because this was a great success story, as somebody said here in the chat. Do you want to say something to the children? To the kids that might be younger than you with TB? To be brave?
As a kid, to my fellow kids having TB, I will advise you that you should follow the rules and regulations given to you by the doctors. Look, although it's not easy, taking drug for good 9 months every day is not easy, but you have to take the rules and regulations given to you by the doctors and always use your drug regularly. Because TB is a dangerous disease. If you don't take good care of it, it can grow bigger in you. Try to use your drug every day. And to parents, make your child feel better, make them happy, make them feel special, and always advise them on how to take the drugs always. To kids, to my fellow kids having TB, I would like to advise you that you should take your drug regularly. Although taking TB every day is not easy, but you have to take it because taking drugs for good 9 months is not easy. Look at me here. I use it for 9 months and I'm well and I survive it. Look at me, I'm the one. And I'm free, I'm healthy, I'm happy. I'm happy today. Look at me, I'm happy. So try to take the drug.
That's very cute.
Thank you.
Thank you so much. That was really very nice. And
Thank you.
you are very brave, but also I have to say, as somebody wrote, it's a success story. And I have to say that in Nigeria, there is a very strong TB program. And with people that care about childhood TB. And just recently, there was, some very good social media moment by the Nigerian colleagues from the TB program on children with TB, and the fact that at least 70,000 children with TB were diagnosed and treated in the year of 2020, last year. So it was good because you had the treatment and you had the good recommendations, and it's absolutely great that you are cured and happy. And I love your messages of please follow doctors' recommendation and the guidelines and the treatment. I think I want to say that it was great you were here with us. One question that somebody is asking that maybe, I don't know if you guys are aware, but if you know, how did you get TB? But you know, there are a lot of questions like this. I think it's a good point. We will try to see if we have this information, if there is any information on how did you get TB. But, and I know that we are discussing on that, and I will turn immediately to you, Jeffrey, but there are some in the chat, some points about some places in which childhood TB seems either not to exist or not to be diagnosed. And I honestly think that this is not because childhood TB was eliminated there, but that probably the diagnosed part is somehow needs some improvement, because I think we all know that childhood TB is pretty difficult to diagnose. So we will have a section on that. We stay tuned. I think the contact tracing and identifying who gets our children sick with TB is very important. But I think it's time now to move, and I think we should keep that ball rolling. I like the conversation on the chat, but I'm turning now to my colleague, Jeffrey Campbell, as I said, coming from the Boston University, as well as the Avedisian School of Medicine. And also that will take forward with the speakers and continuing on this webinar. Jeffrey, the floor is yours.
Great, thank you so much, Dr. DTU, and thank you to our excellent and inspiring opening remarks by Mr. Itani and by Sadia and Mr. Papasu. Very, very much appreciated. So thank you so much once again to all of our speakers and to our audience for joining us today. Once again, my name is Jeff Campbell. I am a co-editor of the recent supplement on pediatric TB in the Journal of the Pediatric Infectious Diseases Societies, from which our talks today have been drawn, as Dr. DTU mentioned. The supplement covers the topics we'll be discussing today, as well as excellent articles about tuberculosis in children living with HIV, the pediatric TB infection care cascade, and new pediatric TB therapies. So please, if you haven't found it already, please check out the supplement. I'll be moderating today on behalf of my co-editors of the supplement, Drs. Gabriella Lamb, Dr. Melanie Dubois, and Dr. Bob Husson. I also want to make a special acknowledgement of the Stop TB Partnership, the Japanese government, and the Pediatric Infectious Diseases Societies who supported the supplement and the webinar. I'm now going to walk you through our stellar collection of speakers, each of whom were lead authors on several of the articles in the supplement. We will first hear from Dr. Devin Jagannath, who is a pediatric infectious diseases physician and assistant professor of pediatrics at the University of California, San Francisco, where he focuses on the improvement of TB care in children and adolescents through the development, evaluation, and implementation of novel diagnostics and digital health tools. Dr. Jagannath will present findings from a narrative review of social determinants of adherence to TB infection and disease treatment. Next, Dr. Suvanand Sahu will present an overview of the impact of the COVID-19 pandemic on TB care and prevention. Dr. Sahu is a physician and the Deputy Executive Director at the Stop TB Partnership, where he has led policies and collaborations that have advanced TB care delivery and equity. Our next presentation will be from Dr. Taufiq Rahman, who is a technical officer with the Stop TB Partnership, where he has led innovative public health interventions and grants to address global pediatric TB. Dr. Rahman will present results from TB Reach program, which supports TB innovations to address global TB response gaps. We will then turn to Dr. Francesca Basile, who will present key updates in the field of pediatric TB diagnostics. Dr. Basile is a pediatric infectious diseases physician and research fellow in pediatric TB diagnostics at the Oxford Vaccine Group at the University of Oxford, where her research focuses on developing and implementing novel TB diagnostics. Finally, we will hear from Dr. Lisa Marie Cranmer, who is a pediatric infectious diseases physician and assistant professor of pediatric infectious diseases at Emory University, where her research focuses on detecting and preventing TB among women living with HIV and their children. Dr. Cranmer will present an update on pediatric TB vaccination. Before starting our presentations, I want to go over a few housekeeping items for our listeners today. First, as you have seen, we will plan to record this webinar, and it's already being recorded, and we will plan to post and distribute this after the webinar is completed. Second, please feel free to enter questions into the chat box for our speakers throughout the webinar. However, because we anticipate being somewhat tight on our timing today, please wait to raise hands to ask verbal questions until the very end of the webinar during our Q&A session. Speakers, please feel free to address questions in the chat as they come up, or wait to address the questions verbally during the Q&A. If there's time remaining during the Q&A session, then we can open the floor to audience members to ask questions directly to our speakers. Thank you all so much once again, and now on to our speakers, and we will begin with Dr. Jagannath. And Dr. Jagannath, the floor is yours.
Thanks so much. All right, well, again, thank you so much for this opportunity to discuss our review on the social determinants of adherence to treatment for tuberculosis infection and disease for children, adolescents, and young adults on behalf of my fellow co-authors. So as we just heard really from this powerful story, we need to recognize that the treatment of TB infection and disease is challenging. We're asking individuals and their caregivers to take medications for months for both infection and disease. And we can see this challenge is reflected in the proportion of children, adolescents, and young adults who are completing treatment, which is low for TB infection and suboptimal for TB disease. At the same time, the risks, progression, and outcomes of TB infection and disease are well known to be influenced by social determinants at the household, community, health system, and structural level, and drives global inequities in care. And there's been considerable work to understand and address the social determinants of TB adherence in adults with several potential interventions, including digital adherence technologies and social protection programs or cash transfers. But unfortunately, there's really been limited work focused on children, adolescents, and young adults. And understanding the social determinants of TB adherence in children, adolescents, and young adults can support adaptation of some of these strategies, but also development of unique strategies for this group to provide family and patient-centered care. So our main objective then was to summarize the current knowledge on the social determinants of treatment adherence for children, adolescents, and young adults to guide efforts and policy to address their unique needs. First, I just wanted to clarify a few definitions that we used in this work. We define child as being less than 10 years old, adolescents 10 to 19 years old, young adults 20 to 24 years old. And in terms of just clarifying the term social determinants of health, as defined by the WHO, thinking of them as the non-medical factors that influence health outcomes. There are these conditions that people are born and grow, work, live, and age, and are influenced by these wider set of forces and systems that shape their daily life. In terms of our methods, we reviewed the literature for articles on adherence as they were related to children, adolescents, and young adults. And we took these work and we tried to map it onto a conceptual model to have a stronger understanding of how these social determinants could influence TB treatment adherence. And so overall, the studies conducted on social determinants of adherence in children and young adults mapped onto an ecologic model that highlighted barriers and facilitators at the structural and community level, health system level, household and caregiver level, and at the individual level. At the same time, some factors were persistent across age categories, as we can see, but then other factors reflected the changing developmental needs as children reached adolescence and young adulthood. So we'll focus at each level, starting with the structural and community factors. And we can see that it influenced adherence at all stages of childhood, adolescence, and young adulthood. In terms of barriers at the social and community level, anticipated stigma and discrimination negatively impacted adherence, whether due to stigma directly from TB or related co-infections, including HIV. And there were concerns, especially among adolescents and young adults, of how it could impact their future relationships, whether romantic or sexual, or future marriage prospects. In terms of community level poverty, this can have a large impact on the resources that are available to individuals to access TB care, including available facilities or transportations to be able to access care. There are also studies on community-based violence's role on adherence, and while the exact relationship is likely multifactorial and related to community-based poverty, there may be direct or indirect pathways that can influence adherence. And lastly, it's important to recognize that gender norms can influence health-seeking behavior or influence the type of care an individual may receive. Conversely, having community and peer support can support treatment adherence, as exemplified in the story we heard, but also in the qualitative study that was done among children with MDR-TB in South Africa that showed that stronger community and peer support, those children did not show signs of internalized stigma. Social protection programs have been proposed to support adherence in adults with promising outcomes, but there's really been limited work in children. But there was one study among adolescents and young adults that showed that if they received government cash transfers, they were less likely to have an unfavorable treatment outcome. Next, moving to health system factors, we can see also that these influence children and adolescents and young adults really across the age spectrum. In terms of barriers, provider beliefs, such as the utility and risk of TB infection treatment, or really the level of counseling, could significantly influence a patient or caregiver's adherence. An additional challenge in childhood TB care is that it may be quite centralized and requiring a patient or caregiver to go to a referral facility. And that places additional challenges to access care, but also potential loss to follow up when we try to link these individuals back to a primary care facility. And then there's a number of treatment-related factors to consider, such as medication stockouts, the pill burden, as was described in our story, that the number of pills that are required either to swallow for an older child or adolescent or young adult, or having to crush or provide these medications to young children on a regular basis is really challenging. And then there's a number of issues related to pediatric formulations to ensure that they have easy dosing, that they're palatable, and also the challenges of the prior need for injectables for multi-drug resistant TB. For facilitators, there have been studies that have shown that decentralized TB care can improve case detection and treatment success. And there's been formative work among adolescents and healthcare workers that have highlighted that the adolescents and young adults do have unique needs that are specific to their developmental needs, and that there should be services that are tailored to them. In terms of treatment, there have fortunately been several advancements, including shorter rifamycin-based regimens for TB infection or fixed-dose combinations and all-oral MDR regimens. And while there's some evidence of improved completion among some of the shorter rifamycin-based regimens for TB infection, there's really limited evidence on how fixed-dose combinations or all-oral multi-drug resistant TB regimens might support adherence. So then as we move to household and caregiver factors, we can see how caregiver-related factors may influence more childhood and early adolescence, though resource needs and support really can impact both the caregiver and household, as well as the adolescent and young adult. Several studies have highlighted how households and families face large financial burden, which is exacerbated by having a child and others in the household with TB. And that can influence healthcare decisions when balancing other priorities like maintaining a job. For children, caregiver attitudes, beliefs, and knowledge can further influence adherence, whether it's the belief that an asymptomatic child may not be at risk of TB disease progression, or whether treatment can be stopped as soon as symptoms resolve. At the same time, caregivers felt more prepared to support treatment if they received appropriate counseling, education, and support by their providers. And again, social protection programs specifically for the caregiver or the household may support adherence and improved outcomes, but there wasn't really evidence to describe this currently. Lastly, there are individual factors for which the literature is largely focused on adolescents and young adults. And in part, that's a reflection of recognizing the developmental changes of this group, the greater need for autonomy and independence, shifting reliance from caregivers to more peers and partners, and a focus on short-term gains over long-term gains. And these likely can influence the knowledge, attitudes, and beliefs that impact TB treatment adherence. Also, as we get to this group, there is evidence to show that having other medical issues such as HIV or substance use or mental health issues can further make completion of treatment challenging. And for mental health, it's important to recognize that TB can further exacerbate these issues through the related stigma and isolation. At the same time, educational attainment is associated with greater adherence. And while it's not been greatly explored in the TB field, for HIV, there has been a large focus on supporting self-efficacy to improve adherence, with some evidence that it might be helpful for TB infection treatment. There are limitations to this review. Overall, there were few studies on this topic, and for children, most of it was related to TB infection, in general related to isoniazid preventative therapy. The past studies for childhood TB have often created this cutoff of less than 15 for children, and that while adult studies have focused on individuals 18 years and older. And so that creates a gap in the literature for older adolescents. There were gaps geographically that can inform additional understanding of social determinants. And ultimately, there were a few studies on intervention development and evaluation and the evaluation of how these interventions could improve outcomes. Overall, we highlight a number of research needs in the paper. And while I won't go into large detail, I wanted to highlight that we need to understand more of the pathways of these facilitators and barriers, and look to adapt interventions in adults, such as for digital adherence technologies, and develop child and adolescent and young adult specific interventions. And we need to recognize that the developmental stage is an important dimension that we need to consider in any intervention. So in conclusion, the social determinants of TB adherence among children and adolescents and young adults occur at multiple levels and are further informed by their developmental stage. And so as we really need multi-level, developmentally sensitive interventions that are needed to address these barriers to TB adherence and support family and person-centered care. And more research is needed across the age and developmental spectrum to inform and evaluate these interventions. So thank you again for this opportunity, again, on behalf of the co-authors for this work, and a special thank you to the supplement editors, JPIDS and Stop TB, and our funding for supporting this work. Thank you so much.
Thank you so much. This was great. And I'm really encouraged by the fact that we grow in number. And I also want to say that Sedia and Mr. Papasu are here with us, and I love them both. So greetings again. And everything that, and I want to recognize, Devon, all the very clear and synthesized ways that you shared your thoughts here. And I encourage everyone to post their questions online, or also to get engaged into the question and answers as we go. So without further ado, because actually for the very first time since I'm chairing, we are kind of in time in my entire career. I would like to introduce the next speaker, which is actually my colleague, but he worked a lot with the entire team and colleagues here, and with Jeff and everybody for this supplement. I am giving the floor to Dr. Sahu Suvanand. He's the Deputy Executive Director of the Stop TB Partnership, on sharing with us, exploring the impact of the COVID-19 pandemic on tuberculosis care and prevention. Sahu, the floor is yours, please.
Thank you, Luchika, and thank you, Jeff. I hope you can see my screen. Yes, so I will present a paper that I and Eliud and Nim wrote together, and this was on exploring the impact of the COVID-19 pandemic on tuberculosis care and prevention. Now, if we are in 2023, if we recall the period of early 2020, there was a lot of confusion in the world when the COVID virus spread very rapidly and caused havoc. So two things happened. One, the people's ability to access TB services decreased. And this happened because of the lockdowns, the restrictions on the transportation, and also the stay-at-home messages that were coming from governments. There was also a fear to visit health facilities. If you visit, you could get COVID there. There was also stigma because anybody who would cough, and TB has common symptoms, TB and COVID, cough and respiratory symptoms, there was a lot of stigma. So people could not access, they could not take health-seeking action in time. So there was postponement of health-seeking action. On the other hand, from the supply side, the TB service delivery was disrupted, and because of several reasons. Number one, the TB human resources, laboratory equipment or laboratories, clinical services, they were shifted to COVID-19 response. And it happened because TB is a respiratory illness and there was expertise there. So in high burden countries, it was very logical to look towards TB. But TB programs did not have the surge capacity because they were chronically underfunded. So they didn't have the capacity to deal with two diseases at the same time, TB as well as the COVID. At the same time, health facilities got overwhelmed by the demand for COVID-19 services. There were active case finding activities happening in the communities that halted. And health workers' capacity to interact with people decreased because of the lack of the personal protective equipment and lack of airborne infection control practices in health facilities. So if you look particularly what happened in children trying to access TB care, we saw that TB diagnosis, treatment, prevention were all affected. But if you look at the reports and the data there, the greatest impact was on TB diagnosis. Access to rapid molecular tests decreased. Sample collection, which are very typical of childhood TB, because sample is difficult to get in a young child, gastric aspiration, nasopharyngeal aspiration, and sputum induction. These are procedures which were considered as generating aerosol. So there was a fear of not having them in health facilities. They stopped. Contact investigations, as we know, children get very often infected, most often infected from adults, and usually from contacts, maybe household contacts. Contact investigation stalled. And this adversely affected not only diagnosis of childhood TB, but also the TB preventive therapy, for which contact investigation, as you know, is very important. And also, we noticed that the mitigation and recovery efforts that were implemented in TB programs did not have a focus on children. They had a general focus, all age group, and children often got left behind. So children suffered more compared to adults. Now, here is a table that we present in the paper, and this is for 2019 and 2020. Here you see the data for the TB new and relapse cases that were notified in all ages, and you see in children, 0 to 14 years age group, the third line there. And the drop in all ages for TB notification was 18%, but in children 0 to 14 years was 24%. If you go further down and look at children who were children who had drug-resistant TB, the drop was 42%. Right, so children were more affected than adults. Of course, all age groups did have an impact. TB diagnosis went down. Now, going further into this age group of 0 to 14, the countries report to WHO the age group 0 to 14, and then also 0 to 4 and 5 to 14. So if you look at the drop 0 to 14, it was 24% drop in if you see 2019, 2020 versus 2019 on this slide. And if you look at 0 to 4 age group, it was even a steeper drop of 28%. And mark also that from 2015 onwards up to 2019, the TB notification in children was growing. It doesn't mean that the TB epidemic in children was growing, but it means that because of better diagnosis, notification, and treatment, more children were put on TB treatment rather than missed from diagnosis. Now, since this was 2020 data available when the paper was written, I also have updated it with the data that came later from WHO later in 2022. So you see here the 2021 data, the last bar there is recovery, both in 0 to 14 age group and also 0 to 4 age group compared to 2020, but not yet at the level of 2019. We are still not there. We hope, seeing some anecdotal data from countries, that 2022 will be a better year, and we are very optimistic that 2022 most countries will get back or even exceed the 2019 levels. Now, undetected TB means that undetected TB comes with a very high mortality, and also it transmits. So several modeling efforts were done way back in 2020 to predict what this means for the TB epidemic. And most of them showed that not only they predicted that not only the mortality will go up, but even in due course, incidence of TB will go up. And this was confirmed by WHO in its annual reports, when WHO reported that the declining trend in TB mortality and incidence got reversed. TB mortality increased in 2021 as well as in 2022, and TB incidence increased in 2022. So it had an impact on the incidence and mortality of TB. Now, this was the global picture. Now, countries got affected in different ways in the COVID pandemic. Different waves countries experienced. Some countries experienced more towards early 2020, some later towards 2021. So they were affected in different ways. In general, we saw countries in Asia had a more severe effect compared to the rest of the world. Some countries had multiple waves of COVID. So you see a recovery effort coming up, but then again, a big wave coming and the case notification diagnosis going down. Now, where are we in terms of the UN high-level meeting targets? There was a UN high-level meeting in 2018, which set some targets for 2022, and we are currently off track. The COVID has put us completely off track, I would say. Here you can see only one out of these targets was met, the last one there, which is the TB preventive therapy for people living with HIV, but the rest we are not on track, with 1 year to go still, 2022. One other point I wanted to make here is the targets on children are even further behind. Look at if you look at the 40 million TB treatments for all age group, that's 66%. For children, 3.5 million children to be treated in that period, 54%. So also in drug-resistant TB, the next two bars there, children are far behind the all-age group progress in the targets. Now, there was also interesting scientific discussion, publications on what happens if in a single individual there is TB as well as COVID co-infection. And there were a number of papers on this. There was also a review of what happened, but this is an area where more research is needed. We have pointed out in the paper some interesting facts that it appears like if you have co-infection, the mortality could be much higher than what it is with individual infections. Also some interesting case studies that have been referenced in the paper. Now, recovery happened. All high burden countries did implement recovery efforts. The pace of recovery varied on a number of factors. Very important was the severity of the COVID-19 impact and the way the country responded to it with lockdowns. The level of political commitment for TB, where we had good political commitment, the recovery was fast. And also resources available for recovery. And I will talk a little bit later about the resources. And the country's ability to adapt and innovate and adapt to the new COVID world. Innovative approaches were implemented by TB programs, and there was a lot of sharing of experiences between countries. There was something that came up which was not there in the pre-COVID time, the bi-directional testing for TB as well as COVID for people who come for either illnesses or seeking care. How do you do both of them? Very interesting experiences from countries. Large-scale screening and testing were implemented to catch up with the undetected cases in the community. You saw Sadia elaborate her experience. If I heard correctly, she was detected in a school in a screening for TB. So that shows the value of these kind of activities, and also detecting TB early. Shifting care and prevention from the health system or health facilities to the community level. This was a necessity that, and a lot of tools and processes developed for this process. And use of modern diagnostics and digital tools, even like digital adherence tools, the AI that came and got scaled up because of the X-ray screening that was required, the X-ray AI. And donors did support. Global Fund with its C19RM initiative, TB did benefit from that. And USAID also provided a lot of technical support for recovery. The lessons learned from the COVID pandemic, many, but here we summarize only 5 of them, that case finding activities can happen at scale using modern tools, not microscopy or old tools, for screening, X-ray with AI and contact tracing can happen at scale. A lot of learnings happened from the COVID pandemic. Use of modern digital tools and medical, if you use modern digital tools, you can really deliver medical care and public health interventions that are required for TB at the community level and at the home level, the houses of people. Real-time data became available. And people, there is possibility now to use real-time data than data that is retrospective, coming after a quarter or a year. Faster research. For the first time, people believe that we can fast-track the progress that has been made in TB in diagnostics research, therapeutics, and vaccines. And also interesting way that clinical trials can be fast-tracked, innovative approaches for funding for research. And finally, the importance of airborne infection prevention and control. The health system had infection prevention and control, but not the airborne part. And that is now a big opportunity to fill in, and TB programs can play a role. Last, the going forward, we talk about the global plan. The modeling that was done for it shows that despite the setback due to COVID, it is still possible to end TB by 2030. And that's a good news, but it is not by business as usual. Many things have to be done in a different way, comprehensive approach at scale using all the tools we have, and also investing on research. And finally, a new vaccine will also be needed. We have also identified that country TB programs and partners working on child health need to prioritize children for access to TB services, not just the TB program, people who are working on child health. And some of the determinants we need to look at, and especially child poverty and undernutrition. These are big drivers of TB in children. And finally, the increased resources will be required. The global plan actually articulates what kind of resources are needed. And we also recommended that to have a focus on childhood TB, you need a separate budget line well funded for childhood TB. Thank you. And this is the Hello Kitty collaboration that we had on childhood TB. Thank you.
Thank you so much, Dr. Sahu, for that very timely talk, and particularly for these provocative and forward-thinking conclusions, and thinking about how we move beyond the COVID-19 pandemic in our approach to TB eradication. It's my pleasure next to introduce once again Dr. Tawfiq Rahman, who will be presenting on TB Reach.
Thank you, Jeff, for the introduction. I, on behalf of all the authors of our article, today will present the summary overview of the article that we just published. And the summary includes innovations and findings from TB Reach projects that were implemented in 18 countries to improve the child TB detection. So as we can see, the global tuberculosis report that was out recently in 2022, with child TB, an estimated 1.15 million children were developed TB disease during the year 2021, which is 11% of all the TB that were estimated during that period. And only 39% of the estimated children were diagnosed and linked to the treatment. And during the same period, 299,000 children actually died from TB, which is around 18% of the estimated child that were developing TB during that period. But some modeling studies suggest that up to 25% of the children who develop TB can die from the disease each year. And this situation is even critical in the age group of 0 to 5 years, where the detection gap is even higher, around 72%. And they also have the highest risk of developing severe forms of TB disease. And among all the child TB deaths, 80% of the child deaths are within this group. So there are a number of challenges related to the child TB detection. Some of the relevant are the lack of awareness among the healthcare staff, as well as in the communities regarding the child TB disease. There is an absence of integrated approach to screen children for tuberculosis. Children present with non-specific symptoms, and it is often related with the difficulty in expectorating sputum, and there is a low bacterial load in the respiratory secretions. And we don't have we have a scarcity of tools that have adequate diagnostic accuracy at our hand. And these tools are often not available at the decentralized settings. And people or children have limited access to experienced clinicians who have the experience or confidence to diagnose children with TB. And often the physicians who have less experience are hesitant to initiate children on a longer anti-TB treatment without any confirmatory TB diagnosis. So a quick overview of the TB Reach grant platform. So TB Reach is the grant-making platform designed to improve TB detection. It receives the foundational support from the Global Affairs Canada, but is supported by multiple donors. We usually fund the local innovators through competitive calls for proposals, and we support innovative approaches and technologies to find and treat TB disease, drug-resistant TB, as well as TB infection. All of our projects at TB Reach undergo a rigorous monitoring and evaluation, which aim to document the experience and link the impactful intervention to long-term sustainable funding. So the objective of this exercise were to present the key findings from the TB Reach projects, which were focusing on childhood tuberculosis, that may serve as a models for the country to adopt or scale up to improve the child TB detection in the high burden settings. Our overall goals were to report the results of the TB screening cascade from the children and document the additional number of children that we identified through these interventions. and overall extracting the key findings from the different innovations that can inform the future interventions or approaches. So the methods, how we selected the projects under this review. So far we have completed 7 funding waves at TB Reach, and the wave 8, wave 9, and wave 10 are ongoing. And at TB Reach, we have a online grant management system where the grantees provide detailed technical and financial data quarterly. And we reviewed all the reports that we received from these completed 7 waves, as well as if any published results were available from these projects, to document the interventions and group them based on the approaches that they used. And we reviewed all the 297 projects from these 7 funding waves and identified around 27 projects that had childhood tuberculosis in their intervention, which were implemented in 18 different countries. And they reported child TB specific data as well. And among these 27 projects, 18 focused exclusively on increasing the child TB detection or prevention aspect. And 9 of them also included some adult as part of contact investigation process. And for the additionality calculation and cascade care analysis, we only included the 18 projects that have age disaggregated screening data. However, all the 27 projects were reviewed to extract the learnings. So based on the review, all the interventions were grouped into 3 main areas. The case finding was the first area, which included facility-based systematic screening, then the household contact investigation, as well as the TB preventive treatment. The second area was improving the TB diagnostics that used new tools as well as alternative specimens. And the final area was grouped into capacity building, which included decentralized care delivery model and supported diagnostic mechanism. So among the case finding approaches, contact investigation was often the main intervention that looked for children with TB, where the child contacts of index bacteriologically positive pulmonary TB patients were screened, and they were then linked to the health facilities to complete their diagnostic evaluation whether they have active TB disease. Often these children and families received the diagnostic and transportation support during the process from the projects. Some of the projects also use innovative tool to improve the contact investigation method. Like one of the projects used a 10-point scoring system to quantify the TB exposure within the household, and which was found effective to find TB household contacts within the family. And some other projects also use reverse contact investigation to identify the source case, as it was mentioned earlier, that we assume that the adult is the source case at the home or where the child got contacted. And also some projects use retrospective contact investigation, where the household contacts were a cohort of index patients who were identified 2 years prior to the intervention of the process. So it was a retrospective cohort. And the projects also used mass screening among children at the health facilities. These were the children who were already at the facilities to seek care for different ailments other than TB. And these facilities include peripheral level primary care facilities to high volume tertiary care facilities, both in the public and private sector. And within the facility, the settings were outpatient and inpatient child TB wards, malnutrition ward, immunization, antenatal IMCI units, as well as HIV clinics. And these projects also worked to prevent the progress of active TB disease and introduce TB preventive treatment, as many of the projects introduced newer and shorter TPT regimens in the countries through the projects. And the projects also expanded the TPT coverage to older children. Usually it was initially practiced under 5 years who were more vulnerable. But with going forward with the UN declaration of the targets, then the TPT coverage was expanded to older children, adolescent and adult contacts as well. And they, during the process, involved medical doctors and community workers, which improved the uptake of drug for tuberculosis preventive treatment. And to improve the adherence, the projects also involve the women-led social support groups in the community. And some projects also use innovative tool to stratify the household contacts who are eligible for TPT. So over the period, 18 TB-Reach projects screened around 2.76 million children through facility-based screening as well as household contact investigation. And 7% of the children who were screened were identified as presumptive TB children, and 75% completed the diagnostic evaluation process. And around 14,000 children, which is 10% of those who were evaluated, identified as having all forms of TB disease, slightly a bit higher than 2% had the bacteriological confirmation when they were diagnosed. And 96% of the children were then linked to treatment. If we look into the number needed to screen to find one child with TB, it was 223 for the facility-based screening and 70 for the household contact investigation. And number needed to test for finding one child TB patient was 10 for the facility-based screening and 9 for the household contact investigation. The projects also use different innovative tools to improve the diagnostic methods. They introduced the gene expert system in the country, including the recent expert MTBRIF ultra cartridges. Projects purchased new digital X-ray machines as well as repurposed some old machines to convert them into digital X-ray machines. And often the children were transported for chest X-ray to the health facilities, or referral vouchers were provided to the families. And projects also helped in the development process of AI algorithm for the younger children, which is yet to be established. And they also evaluated the performance of AI comparing to the human readers during the process. And gastric lavas, stool, and urine were used as alternative pediatric specimens in the facilities. And clinicians and other healthcare workers were oriented who received hands-on training on the collection procedures. Some projects set up a child-friendly outpatient unit at the facilities to overcome the challenge related to collection procedure of the gastric lavas, which often require the overnight stay prior to the collection day. So it was an outpatient facility, and children come into the morning and is put on, or gastric lavas can be collected on the same day. So while facilitating with the chest X-ray, when introduced to the children or to the algorithm for evaluation, the number of children evaluated for TB were increased by 2 times. And for some instances, the number of children diagnosed with TB increased by 3 times in the evaluation area. And use of alternative specimens also increased the number of children who completed the diagnostic evaluation, and as well as the bacteriological evidence of TB disease in the settings. And apart from these direct benefits, these results were used in a meta-analysis to inform the WHO Child TB Guidance Update. And the AI algorithm data on X-ray will be providing evidence to inform the future WHO reviews on pediatric chest X-ray and AI. As some of the speakers mentioned earlier, that the TB diagnosis is still happening at a higher level at tertiary facilities or at a centralized position. So TB projects tried different models to decentralize this diagnosis process through capacity building of the peripheral facilities, as well as supported decision makings using the digital tools. The projects used their experience from the tertiary facilities and translated the learnings to the decentralized program. And while doing that, they trained the health workers at the primary level facilities to screen the children as well as triaging. And the facility physicians, nurses, and other health staffs were trained. And the projects did a capacity assessment as well as facility assessment, and make sure that they equip the peripheral facilities with the required reagents, tools, as well as diagnostics. The peripheral facilities were connected to a centralized facility through video consultation. In that way, a less experienced physician could connect to an experienced physician while diagnosing some of the difficult child TB patients. And medical boards were formed involving physicians from different specialties, and that helped with diagnosing of child TB based on the consensus by different physicians. And some of the projects employed mentorship using the WhatsApp group, where chest X-ray images or diagnostic reports were shared within the group to receive feedback from experienced physicians. And some projects adopted the free online TB learning program using the ECO project. So with the decentralized model, the child TB notification increased by 100% in some settings. And the video consultation contributed to 25% of the project yield at the project level. And the medical board contributed 14% of the project yield at the project level. So these are the models that can be tested out and adopted in many high TB burden settings. In addition to that, these processes improved or ensured the rapid and quality diagnosis of child TB, reduces loss to follow-up, and decrease the out-of-pocket expenditure related to the travel and the investigation. And it empowered the local physicians with confidence and knowledge to diagnose. So the local physicians were empowered or gained knowledge from the experienced one through these digital technologies, and it helped them to create the next tier of trained trainers. And at TB Reach, we used a structured M&E approach to measure the population level impact on child TB notification. And doing that, we use the baseline notification as well as the intervention period notification. And we also use the evaluation area data and compared that with the control area data. And from the results, we can see that by these 16 projects, an additional 5,200 children were detected and linked to treatment, which was a 17% increase from the baseline. But during the intervention period, the control area at the same time experienced 7% decline in child TB detection, which means around 1,600 less child TB patients were detected during the intervention period. When we see the trend adjusted additionality, we found that the projects increased the notification by 34% over expectations compared to 1% in the control area. And we also tried to see the ratio of project yield versus the actual child TB notification, and we found that around 40% of the patients who were notified were diagnosed by these projects in that intervention area. So considering the future directions for TB program, we believe that focusing efforts and funding on childhood TB can produce marked improvement. We need to support the clinicians with the skills and confidence to diagnose the children. And recently published the clinical algorithm guidance for pulmonary TB under the age of 10 years will be helpful to diagnose more children with TB. And we have to screen more children for TB, and we have to bring the diagnostic process closer. We have to employ different technologies and tools to improve the diagnostic process. And alternative specimens like non-respiratory samples can help, as well as the radiology and AI can help the clinician to improve the diagnosis. At the same time, we have to raise awareness in the community and within the healthcare staff regarding the TB symptoms and risk of TB and the need to screen children for TB. And for the clinicians, they have to consider saving lives, where they have to make the balance between the over-treatment and hesitancy to treat. They have to consider what additional benefit they can bring in diagnosing the children. So to conclude, overall, the detection of TB among children remains a huge challenge globally. The impactful results achieved by these interventions demonstrate the need to include them in the national strategic plan. And a strong political commitment or will from the government, as well as interest from the donor, is required to acknowledge and fund the initiatives that care the vulnerable children. We have to employ the new technologies in an innovative ways, but at the same time, we have to make sure the complicated diagnostic process is facilitated and simplified at the health system facilities. And we believe the knowledge that we gained from these approaches can help the TB programs to achieve much more and reduce the child TB detection gap. Thank you for your time and listening to our experience.
Thank you so much, Tawfiq, for being in time and for being very succinct. As I said, I continue saying that I'm very impressed with our colleagues posting, questions here, and I know that we will address them in that part of the webinar. Without further ado, to keep up with the good speed of these presentations, I would like to go to a very important topic, which is related to the TB diagnosis, present and future. And as we saw here in the talk, and as we all know from our clinics, it's not easy to diagnose TB in children. But thank God, we have more tools and we will have even more. So I'm very pleased to introduce our colleague Francesca Vanda Basile, from the Oxford Vaccine Group, University of Oxford, obviously UK. Francesca, the floor is yours. Thank you.
Thank you, Lucica. It's a pleasure being here this afternoon, morning, or evening. And I'm going to present on pediatric TB diagnostics, present and future, which is a state-of-the-art review. And I'm presenting on behalf of my fellow co-authors, Pamela Nabeta, Morten Ruhwold, and Rin Song. Obviously, it's going to be an appetizer of the actual contents of the review, but hopefully you will have time and interest to have a look at the paper and all the other amazing papers of this collection. So I'm going to highlight in particular the challenges of TB diagnosis in children and focus on the highlights and the present of pediatric TB diagnostics, so what tools we currently have, and then look a bit into the future and what's going to come next in the pipeline. So why is TB diagnosis so challenging in children? Some have been already said by previous presenters, and I just wanted to remark that the diagnostic accuracy of the clinical criteria in children is really poor because of the non-specific symptoms, the age-dependent disease spectrum, and also the chest X-ray findings are really just as non-specific as the symptoms and affected by inter-reader variability and especially cost and accessibility issues in resource-poor settings. But on top of that, we really have a very difficult microbiological confirmation in children because the respiratory specimens are hard to obtain. And the majority of you working in clinical settings know how it's hard for young children to expectorate spontaneously. And additionally, the collection procedures are complex, somewhat always invasive, and really resource intense and need really expert and trained staff. At the end of the day, we are usually left with, at best, really small volumes, which are of posibacillary specimens. And why? Because pediatric disease is just as a definition posibacillary, meaning that the yield, the bacterial load of the respiratory samples that we have is very low compared to the one of adults. There are additional factors that influence the choice of the specimen type, such as acceptability, feasibility, and local test availability. And so really specimens, and talking about specimens for pediatric TB is important to put all these challenges into context. And gastric aspirate and induced sputum, which are the classic, the traditional diagnostic specimens for chest TB, are really non-child friendly and also not user friendly. The nasopharyngeal aspirate that has been gaining momentum in the past years is somewhat a better specimen in terms of being more child-friendly and less invasive than gastric aspiration and has a lower risk of nosocomial transmission compared to the induced sputum. Still is not optimal because it requires trained staff and a lot of equipment like mucus traps or aspirator that are always unavailable, often unavailable in resource-poor settings. So having said that, however, not everything looks so dark. As the majority of you knows, in the past decade, there has been a great improvement, especially with regards to molecular diagnostics, starting in 2010 with expert MTB-RIF that was endorsed in 2013 for children. But one thing to mention is that at present, only TrueLab, that is rapid molecular diagnostic assay that has been really recently endorsed by the WHO, at present is the only molecular tool that is deployable to the primary healthcare level, being this, you can see it here in the presentation, this portable tool, this portable equipment. But TrueLab and TrueNat by MolBio India are currently only conditionally recommended in children, so there is still lack of evidence. And the data that we have for pediatrics that guided the WHO recommendation are just based on extrapolated data on adult sputum specimens. But the majority of you may probably know well Expert Ultra. Expert Ultra that was endorsed in 2017 is the next generation expert that has a higher sensitivity for MTB detection, especially in smear-negative patients such as children. And thankfully, it runs on the same GeneXpert platform as the Expert MTB-RIF, which obviously is great in terms of resources allocation. And what is really relevant for children and for pediatric TB detection is the presence of trace call. That is a semi-quantitative category that indicates MTB at the lowest limit of detection, which for Expert Ultra is 14 colonies per milliliter, which is really a really great achievement of this technology. And while the interpretation of trace is still somewhat debated in adults, for children and people living with HIV, that should be interpreted just as a true positive finding. So any child with a trace positive result should be treated and move forward in the TB care management. An additional great novelty since 2021 is the introduction of stool for the diagnosis of childhood TB. And I believe many of you already know that in 2021, the WHO endorsed stool as a non-invasive primary TB diagnostic specimen for testing with expert. This recommendation was based by a systematic review that was just updated in September 2022. And the Expert Ultra stool sensitivity compared to a culture positive reference standard was 53%. However, it did show some heterogeneity in sensitivity among different age groups, age strata. And interestingly enough, especially in the very young children, the tiny infants below 1 year, had a quite good sensitivity of 65%. And specificity is really good. So why we like stool? We like stool because it's a non-invasive and super chat-friendly specimen. It is somewhat cheaper in terms that it requires less consumables or resources compared to gastric aspirate, induced sputum, or nasopharyngeal aspirate. It has a high acceptability and collection does not require trained staff. There might be some concerns regarding the TB lab and the processment of stool specimens. At the moment, we have 3 processing techniques that are recommended, and they all have a similar diagnostic accuracy, and that's an interim analysis based on a head-to-head comparison trial. But one of them in particular, the SOS, simple one-step, is particularly relevant as it doesn't require additional materials other than an applicator or filtering or centrifugation steps. So it's really a straightforward process from stool sample collection to running stool on GeneXpert. And it was developed and is currently undergoing some fine-tuning by the KNCV. And stool is then a really great specimen for district level use in combination with expert. However, I think also shown a bit in the previous presentation, it's really important that we have good structural interventions and capacity building so that stool really can be deployed at the peripheral or community settings and be embedded in decentralization strategies. But obviously, this is going to require more operational research. An additional topic that is really hot in pediatric TB diagnosis right now is testing strategies and combination of different specimens. You can see in this paper by Heather Sauer group that the sensitivity of ultra resembles that of culture when we combine multiple samples, such as 1 MPa and an induced sputum, or 2 MPAs and 1 induced sputum. However, there are concerns regarding the feasibility of collecting multiple specimens and cost issues in resource-limited settings. However, also in a cohort of very young children under 5 that are classically the hard to diagnose in Kenya, 2 MPAs or 1 MPA and 1 stool sample, interestingly enough, reached a very high sensitivity that was similar or even superior to that of the criterion standard specimens, which are either 2 induced sputums or 2 gastric aspirates. And repeating stool sampling could be another option to increase the diagnostic yield. And just to mention, because in pediatrics, feasibility and acceptability are really key, that combining MPA and stool samples was deemed highly feasible at the district level. And this is results from the TB SPID project that are still unpublished. So what is going the future of pediatric TB diagnostics look like? The research is really focused on finding novel, more accurate diagnostic tests to increase the proportion of children with confirmed TB. We are trying to find even better combinations of specimen types and child-friendly specimens, novel approaches to rule out TB that are also called triage tests, and also omics approaches to find novel biomarkers. Obviously, all proteomics, transcriptomics, lipidomics are burdened by costs, but in terms of getting to find ideal candidate biomarkers, they are definitely going to be a very helpful tool. And at the end of the day, our holy grail is really a test that can be used in affordable diagnostic algorithms at the point of care and in peripheral settings. And really the development of more sensitive pathogen-based assays for use on non-respiratory specimens and the expansion of tests that are host-based, so they use host response to MTB as a measure, are considered high priority. There are several assays that are in different stages of development, but really many of them hold promise for pediatric use. And you can see that in this table from the review, a lot of commercially available or in mid-stage late development tools are still pathogen-based, meaning that they are aimed at detecting either tubercular antigens or the mycobacteria itself, and still require traditional specimens like sputum or other respiratory ones. So it doesn't look so great. But one of the big novelties that hopefully is going to become a reality in pediatric TB is oral swabs. Oral swabs are child-friendly specimens. They are universally obtainable with minimal discomfort or need for operator training, so they are operator-friendly as well. And while they are not really useful likely as a standalone test, and you can see that sensitivities are not really exceptional, they could really be potentially useful in combinations and in algorithmic approaches or testing strategies. And these current sensitivities that come from just few very preliminary studies might actually improve with fine-tuning of the collection methodology, like swab type, collection media, and anatomical site. That could be improved. And they are really interesting for potential use with portable hardware and in decentralized testing strategies. With regards to host-based assays, what's close in the pipeline in terms of the development is RNA signature assays. And one assay that is really now being studied in pediatrics in several studies is the host response cartridge. Host response cartridge is this cartridge-based prototype that runs on the GeneXpert platform, which is really good. And it measures a 3-gene mRNA signature in capillary blood. So the specimen can be collected just as easily as with finger prick or with a heel prick collection. And in adults, in an interim analysis, it did achieve the minimal thresholds for a triage test. Pediatric studies are ongoing, and we should look at them with some optimism as pediatric databases were included at the developmental stage of this 3 gene signature that the cartridge is measuring. Just to mention quickly that there are additional interesting biosignatures that have achieved high sensitivity and specificity, or good ones, that could potentially make those host-based assays good triage tests. So what is this triage test that I've been mentioning now a bit? It's essentially a test that has high sensitivities, but not so great specificity, or at least not very high specificities, that can really help us identify a cohort of symptomatic children to move forward in the diagnostic process and where to concentrate our efforts of additional diagnostics, and be a good rule-out test, meaning that children with very low pretest probability of TB and with a negative triage test result would then not investigate it further and save some resources and concentrate them where they are most needed. And clinical algorithms might also be part of this reasoning. And they have really shown, especially one of the latest algorithms presented, shown a very good sensitivity, but the key weakness of clinical algorithms is still specificity. However, as also previously mentioned, the WHO is also promoting the use of data-driven algorithms, and this is just from the latest WHO guidelines on adolescent and childhood TB, but we do need pragmatic studies to assess the validity and acceptability of such tools. And hopefully in 2 years' time, the presentation will be different. And just to conclude, and computer-aided detection of radiographs has been mentioned by Tufik just previously. And at the moment, we don't have any pediatric data officially available, but there is a lot going on, as you've heard. They are a reality in adults now. There are, however, some challenges or potential challenges in children because of the non-specificity of the radiographical presentation, and also setting variations. We will need to take them into account. So it's really important that we do test the softwares and the algorithms and train them on extensive chest X-ray libraries that are specific to pediatrics. So to conclude, I hope this whistle-stop tour was not too rushed, but there is really a lot. However, despite remarkable progress today, pediatric TB diagnosis is still challenging, as you've seen, and late stage of or design-locked prototypes need validation in pediatric population, and still most products are sputum-based and present cost and scalability issues. True point-of-care tests, non-respiratory specimens, and combinations of samples are really research priorities and will be super helpful for service decentralization. Clinical algorithms, biomarker assays, and CAD all promise as triage tests, but we still need accurate confirmatory tests that are likely going to be pathogen-based ones. And operational challenges and pediatric-specific needs must be addressed really in early phase studies and pragmatic trials at the point of care. And thank you so much to my co-authors and all the editors and Stop TB partners. Thank you.
Thank you so much, Dr. Basile, for a really clear presentation of a truly massive scientific field. There are a number of questions that have been posted as you were speaking, which I'll draw your attention to in the chat. And I also just want to say that for any questions that Dr. Basile or other authors are not able to address in the chat or the Q&A session, we will plan to send these questions to our speakers as well, and hopefully circulate some answers after the webinar is over. So to introduce our final speaker for the morning or afternoon or evening, I'm pleased to reintroduce Dr. Lisa Marie Cranmer, who will be presenting an update on pediatric TB vaccination. Dr. Cranmer.
Great. Well, thank you all for your amazing attention during all these excellent talks. Thank you for having me today to discuss what's old and new in TB vaccines for children. I have no conflicts of interest, and today I'll begin with discussing the current landscape of pediatric TB vaccines from past to present. We'll then move on to address the uphill climb, the unique challenges of TB vaccine development, and lastly, discuss opportunities to accelerate the pediatric vaccine pipeline. TB vaccine history has been a really long road, encompassing more than 100 years. TB was first discovered by Koch in 1882. Mycobacterium bovis bacillus was attenuated by Calmette and Green in 1908 to create the BCG vaccine. And the first vaccine was administered to a human infant in 1921 and endorsed by the League of Nations in 1928. Despite a widespread global uptake of BCG vaccination, TB cases have continued to rise. And the WHO identified TB as a global health emergency in 1994, yet BCG vaccine remains the only licensed TB vaccine today. For the last 20 years, TB has claimed roughly 2 million lives per year. And while this has declined over time, we're now seeing an uptick in TB mortality fueled by the COVID pandemic and as noted by other authors. Children account for 16% of all TB deaths, and over 96% of children who die from TB did not receive treatment because their TB wasn't recognized. BCG provides over 80% protection against disseminated TB among infants, including robust CD4 T cell responses, and is the most widely administered vaccine globally, with over 100 million doses given every year. However, BCG has inconsistent vaccine efficacy to prevent pulmonary TB in adults, ranging from 0 to 80%. BCG also poses safety risks to immunocompromised individuals, causing vaccine strain disseminated disease, and has had a lack of standard manufacturing procedures that leads to different strains being used globally. Supply chain shortages have led to gaps in coverage, with resulting upticks in cases of TB meningitis in infants. So after 87 years of BCG as the only available TB vaccine, the quest for new candidates in children began in 2008 and have included viral vector, adjuvanted proteins, and both live and killed whole cell TB vaccines over the past 14 years. There are two main strategies for TB vaccine candidates in children. First, prevention of TB infection among uninfected children who have a negative interferon gamma release assay testing. And second, prevention of disease among IGRA-positive children with the outcome of microbiologically confirmed TB disease. And defining TB vaccine target age groups in children is driven by epidemiology. There's a very high incidence of TB in both infants and adolescents, and TB clinical phenotype also differs by age, with lymph node and disseminated disease highest in infancy and a corresponding high risk for mortality. Adolescents develop more adult type disease with pulmonary cavitations, which derives ongoing TB transmission. Modeling studies have shown that TB vaccine targeted to adolescents has the greatest public health impact, averting significantly more TB cases per year, even with poor to modest efficacy seen in the red and blue lines. And the authors conclude that over 25 years, a vaccine with modest efficacy is estimated to prevent 17 million deaths when given to adolescents, compared to only less than 1 million deaths when given to infants. Therefore, there's been an increased number of trials that are evaluating new TB vaccine candidates among adolescents, and current infant trials focus on using live whole cell vaccines as BCG replacement. VPM is a genetically engineered live recombinant BCG strain replacing the urease C gene with listeriolysin. And after the bacillus is phagocytosed, listeriolysin disrupts the phagosomal membrane, and this allows vaccine proteins to be released into the cytosol. And this allows for MHC1 presentation to CD8 cells and enhanced inflammasome activity and autophagy. Preclinical and early clinical trials have demonstrated robust immunogenicity and found that VPM had improved safety profile with improved survival in SCID mice and no disseminated disease in animal models. The VPM 1002 manufacturer, SII, has optimized production steps to enable rapid scalability and vaccine distribution. A phase 2b trial of South African infants exposed to HIV and unexposed newborns has demonstrated that VPM 1002 had non-inferior safety compared to BCG, with lower grade 3 generalized lymphadenopathy in the VPM arm. VPM was also significantly less reactogenic, causing scarring in less than a quarter of vaccinated subjects, compared to 75% of BCG recipients who developed scarring. Children had lower rates of ulceration and abscess formation in the VPM trial arm. However, multifunctional CD4 and CD8 cell responses were lower in the VPM arm compared to BCG. A phase 3 trial is ongoing with endpoints of preventing TB infection and TB disease in infants with nearly 7,000 participants. And a phase 1/2 trial among pre-adolescents living with HIV, with and without HIV, is currently being planned, anticipated to start this year. A second live vaccine candidate to replace BCG in infant trials is MTB-VAC. As opposed to BCG, which is attenuated from M. bovis, MTB-VAC is attenuated directly from Mycobacterium tuberculosis. This retains 25% of the TB T cell epitopes that are absent in BCG, and this preserves antigenic diversity. To ensure safety, the FOP and FAD-D26 genes encoding the TB virulence factors were deleted from this strain. Preclinical studies were reassuring for safety in SCID mouse models, and MTB-VAC demonstrated lower TB burden in the lungs compared to BCG after MTB challenge. A phase 1 dose escalation trial of MTB-VAC versus BCG conducted among South African infants found that no vaccine-related serious adverse events occurred. There was one unrelated death that occurred in the vaccine arm, but MTB-VAC had similar reactogenicity profile to BCG, and the highest dose of MTB-VAC elicited higher frequencies of CD4 T cells through 1 year of age. And notably, there was a dose-related increased frequency of IGRA conversion among MTB-VAC recipients, and this is due to cross-reactivity of the vaccine with ESAT6 and CFP10 antigens that's present in the commercial IGRA assays, which could limit the use of MTB-VAC for prevention of infection trials. So to date, a dose-finding phase 2 trial has been completed, and a phase 3 efficacy trial to prevent TB disease among exposed and unexposed infants exposed and unexposed to HIV started at the end of 2022. So moving on to adolescents, a recent trial of BCG revaccination demonstrated 48% efficacy to prevent sustained IGRA conversion among adolescents without HIV and without IGRA positivity in South Africa. So this also showed 45% efficacy to prevent high magnitude quantiferin conversion, which may have clinical significance, as this cutoff of greater than 4 has been associated with a 30 to 40-fold increase of risk of TB disease in children and adults. An ongoing larger trial among children aged 10 to 18 is underway to validate these findings. M72 is a recombinant protein of TB antigens, 32A and 39A, plus an organic adjuvant, ASO1E, that's given in 2 doses, 1 month apart. And a phase 2 trial in South African adolescents with and without TB infection showed that the vaccine is safe with no serious adverse events. Solicited generalized AEs were more frequent in adolescents with prior MTB sensitization as detected by IGRA. And M72 was immunogenic, inducing multifunctional CD4 cells, notably of higher frequencies among IGRA-positive adolescents. An exciting development for the TB field was a phase 2b trial in IGRA-positive adults, which found nearly 50% vaccine efficacy to prevent microbiologically confirmed TB disease. A phase 2 trial, including adolescents over 16 and adults with HIV, is ongoing, and a larger phase trial is being planned and anticipated to include adolescents as well. So this is just highlighting the current pipeline of pediatric TB vaccines. I didn't have time to go through all of the potential candidates. One to highlight would be ID93 plus GLASE, which is another subunit vaccine that's in phase 1 trial for safety and immunogenicity in adolescents in Korea. And there are a few other candidates that are upcoming. But of note, there are no phase 1 trials for infants, and also only one phase 3 trial for adolescents. And so we hope that the pediatric TB vaccine pipeline will expand. So I just wanted to highlight a few of the challenges of TB vaccine development. TB vaccine trials are hindered by a prolonged time to the clinical endpoint of TB disease. Prevention of infection trials have shortened the follow-up time needed, but it's unclear if efficacy of preventing TB infection will really correlate with TB's disease prevention. And TB is a very complex pathogen. While COVID has only 30 genes, TB has around 4,000 genes, over twice the amount of Haemophilus influenza, another bacterial vaccine preventable pathogen. Identifying antigenic targets of TB is therefore much more challenging. And the central challenge to TB vaccine field is that immune correlates of TB protection are unknown. Our current measures of immunogenicity do not equal protection, shown by the similar frequency of Th1 cytokine producing T cells at 10 weeks of age, comparing children who later developed TB disease over 2 years of follow-up to both community and household controls without TB. And this challenge was really highlighted when the first large TB vaccine efficacy trial of MV885A had disappointing results. The trial was conducted among nearly 3,000 South African infants. And while MVA85A elicited interferon gamma immune responses by ELISpot and polyfunctional Th1 and Th17 immune responses, there was no efficacy to prevent either TB infection or disease. So the search for TB immune correlates of protection is ongoing, and an NHP challenge model has demonstrated that IV BCG vaccination was highly protective after MTB challenge compared to intradermal and aerosol administration, which has led to further characterization of non-conventional immune markers that may correlate with protection, including IgM and glycolipid-specific T cells. Currently, ongoing human studies are investigating a wide array of potential correlates of protection from MTB infection within the BCG revaccination trial and correlates of TB disease protection using specimens from the M72 trial. And lastly, I'll discuss a few opportunities to accelerate the TB pediatric vaccine pipeline in which we can adapt important lessons learned from the COVID pandemic. So in seeking global support to accelerate vaccine development, COVID taught us a very important lesson, which is to name the problem. So WHO declared COVID a pandemic only a few months after its discovery. And after that, a flurry of infographics have emerged on the internet to compare coronavirus to the most deadly pandemics in history over time, with Black Death commonly being attributed and hailed as the deadliest plague of all time. Yet what's consistently missing from these pictures is tuberculosis. Tuberculosis is an unnamed pandemic. TB was first documented in human skeletal remains as early as 8,000 BC. And while we don't have precise mortality estimates over 10,000 years, I dare to say that it has caused more human death than any other pathogen. TB is a pandemic, and we need to name it a pandemic to fuel global action to develop new TB vaccines. In thinking through our approach, we also have a lot to learn from our approach for the TB vaccine pipeline. We also have a lot to learn from COVID. So to quickly deliver a COVID vaccine, the US government invested upfront in 3 different vaccine platforms with 2 to 3 manufacturers per platform. This allowed lower risk to manufacturers at the start and allowed for a healthy competition to race to the delivery of a COVID vaccine. And so we need to apply these principles to TB vaccine development, which will require large-scale global investment, expansion of vaccine platforms to include RNA and DNA vaccines, and creating a heightened capacity for global manufacturing and market demand. Colleagues have recently published a global roadmap for TB vaccine development, and what we now need is investment and a race to spur on advancement of new pediatric TB candidates. As we aim to accelerate the pediatric TB vaccine pipeline, COVID taught us to also prioritize public health impact. As Walter Orenstein says, vaccines don't save lives, vaccinations save lives. And as we perform TB vaccine clinical trials, we need to work with communities to identify parameters of vaccine acceptability and hesitancy, particularly among high-risk populations, including those affected by HIV. And we also need to work to shrink global equity gaps by enabling widespread access of an affordable vaccine using broad deployment strategies. I would like to thank my co-authors, Cheryl Day, Mark Cotton, and Elisa Nems, as well as PIDS, JPIDS, and the Stop TB Partnership, as well as all the other funders, mentors, and collaborators who've supported my development over the years. Thank you.
Thank you. And because we have a very good collaboration here is I like very much because I feel like we are in, when we are discussing scientific things, and I feel this collective drive and energy here. I think we have 5 to 10 minutes, maybe pushing a bit boundaries for question and answers. And if I can ask Jeffrey with Sahu, if you can handle the questions and answers, It turns out that I have to join something right now suddenly. So I think the questions and the comments in the chat are valuable. So maybe, Jeff, I pass it to you while I say that I love you all. And I think the passion and the work for childhood TB gives a lot of hope that we will see a time in which we will have children without TB. So Jeffrey, I pass to you. And if you need a hand of support, my colleague Sahu will help you. So thank you so much.
Terrific. Thank you so much, Dr. Ditiu. I wanted to maybe open the questions with the most recent chat question that was posed to Dr. Cranmer, and then I have a few other questions that have been posed to other speakers, and maybe we can tie some of these together. But maybe Dr. Cranmer, if you want to take a look at the most recent question from Neela Goswami about direct comparisons of vaccine candidates.
Sure. Thanks, Neela, for the question. I think it's a great idea. Unfortunately, I personally don't know of any direct comparisons with vaccine candidates to IPT or TPT rather. But I welcome others to speak up if they know otherwise.
Maybe then I could pose a question that I think might pertain to sort of all of our speakers that I've been thinking about, and I imagine others have been as well. So this question relates to COVID, and we know that COVID has changed trust in centralized healthcare systems. And I was wondering if you have thoughts about how you see this changed trust in centralized healthcare systems affecting access to pediatric TB care, whether it be through novel interventions that are proposed, access to diagnostics, trust in new vaccines, and willingness to test new vaccines. I just wanted to, maybe see if you would be willing to answer that question as it relates to each of your individual talks.
So Jeff, maybe I can start. So yes, you are right that the COVID experience showed us that people are, there is the centralized health system is not the best way to deliver care to people, particularly because of two reasons. One is, if you think of any, the world is today talking about pandemic preparedness, it will not be good to develop a system where for everything people have to go to a centralized health facility, because what if there is another pathogen like COVID? God forbid it doesn't come like that. But in future pandemics, we have to be prepared and learn the lessons and develop a system where people are offered care right at the place where they are, in the community, in their home. And I think this is one point we need to look at. The second is, today, the tools for medicine are now combined with digital tools. And with that, it increases the possibility of deploying tools in the periphery. So in the past, we had, for X-ray, you have to come to a health facility and get yourself X-rayed in a room. You need radiologists to interpret it. It was quite a process, So today the technology has become so simple that the X-ray, you can hand hold the X-ray machine. The exposure to the X-ray is very minimum with high resolution pictures, which can be deployed in the community, and the artificial intelligence gives you reading within seconds or minutes. So I think that kind of technology changes also, I think, compels us to deploy our diagnostics and the way the care services are laid out in a very decentralized manner. Coming to treatment as well, the past tradition of TB programs of asking people to come to a health facility to get observed should not be the thing for future. We have digital tools to connect with them. Of course, personal interaction is good, but that can be organized in the community. Drugs can be delivered to homes of people, and we saw that happen during COVID. And that experience and that learning we should not forget, and we have to. I see it as a one direction kind of progress, that more and more it'll get decentralized, and we should be prepared for it. Thank you.
Great. Thank you, Dr. Sahu. For other speakers, I don't know if you would care to address this question as well. Otherwise, we can address maybe one or two other questions from the chat. Maybe one next question from the chat then, it could be directed to Dr. Basile. There have been several questions related to stool testing, and I think I've seen you addressing some of these questions, but I wonder if you would be willing to sort of give a general sort of recap or summary of stool testing, or if there are any sort of salient questions that you think would be helpful for the audience to understand about the general landscape of stool testing for pediatric TB.
Yes, thanks, Jeff. I was trying to scroll down into the chat to look and read questions, but yeah, definitely I have read one that probably was worth discussing in a larger forum. That is for stool TB from Nila, for stool TB diagnostics. Are there any operational details you see important to share in terms of storage, etc., before processing with GeneXpert? And yes, potentially. There are studies that are ongoing, and the KNCV group is actually at present doing additional studies where they're looking at different storages and time that can pass from stool collection to processing on Expert, whether or not having some heating steps prior to running the stool specimen on Ultra is possibly going to change the detection rates, whether or not storing in a freezer at -20 or -80 degrees can affect results or could actually improve detection. So there are a lot of fine-tuning going on with regards to stool testing on Ultra, and there are several groups that are currently looking at that. Obviously, one other challenge that we are also experiencing in trials and diagnostic trials is that the time from collection, sometimes at home, to the time where stools are actually brought to the clinic by parents, it's another reason for potential variability. But we're definitely going to try and assess all these issues in studies as we move along.
Terrific. Thank you so much. Yes. Since
I was in the role, there was just another question that I think was also quite interesting to just briefly discuss on saliva for Expert Ultra for diagnosing pediatric TB. So at the moment, to the best of my knowledge, there are no data, and I'm not sure if someone is actually looking at that. For sure, there are adult studies assessing that, and I think results might actually be quite interesting, but they are all smear positive individuals. So for children that are smear negative, it's actually quite unlikely that saliva could have a good yield. And we would really try and look at saliva more as a specimen for biomarker and host response measures, rather than really trying to look for mycobacterium in saliva.
Fantastic. Thank you. In the interest of time, I think we should start wrapping up. I did want to just call attention to one question, which I actually think can be maybe a call to action from Abdullahi Isyaku, who mentions that we generally in this field need advocacy, community mobilization, and I think as opposed to trying to directly address this question, I feel like this should be a call to all of us to think about how we can incorporate advocacy, think about the communities that we work with pediatric TB, to bring more attention, more resources to this problem. There are a few additional questions that we didn't have time to address in these talks, but will be addressed in the articles in the supplement, such as those related to treatment. And once again, we'll plan to circulate a recording of this webinar, as well as additional responses to questions that we weren't able to answer to all of our participants and attendees today. So once again, on behalf of my co-editors, on behalf of Stop TB and Pediatric Infectious Diseases Society, I wanted to say thank you so much for attending today. And we will see each other virtually or in person, no doubt, hopefully very soon. Thank you all.
Thank you.